Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
The stigma, immorality, and indecency implied by the word kept the subject it connotes shrouded in obscurity and prevented many people from acquiring a desire to learn much about it. Secrecy about the disease had been due in great measure to previous conservatism of the medical profession in failing to familiarize people with the facts and to previous reluctance of the press to publicize the data, rather than to indifference of the reading public. Paul O'Leary, Foreword to the Corky Killer by Harry A. Wilmer, MD, 1946.
Hello, and welcome back to Conversations with CEI. I'm Nick Gerbino, public health professional at the Monroe County Sexual Health Clinic in Rochester, New York. I'm joined today by my colleague, friend, and mentor, Patrick.
Hello, my name is Patrick Passarelli. I'm an infectious diseases fellow at the University of Rochester.
I had an opportunity to join the sexual health clinic about 5 years ago now. That was my introduction to working in public health, sexual health, I should say. And so it's been 5 years doing a lot of HIV prevention with PrEP and PEP. So I'm excited for the opportunity to talk about syphilis today.
And I really got involved with STI work early in medical school. I had the opportunity to volunteer at the county jail where I went to medical school in Omaha, Nebraska. And so that was really after taking some time off of studying and teaching and then returning to school. That was the first chance I got outside of the books to really see patients.
Today, we'll be discussing all things syphilis as the current epidemic rages on, epidemiological trends, updates in diagnostics and screening strategies, and finally, some newer studies exploring additional treatment and preventative options for syphilis.
Syphilis is intimidating. Unlike most diseases, its diagnosis and treatment is mired in stigma and sexual mores. The name itself descended from a 16th century poem by Veronese physician Girolamo Fracastoro about a young shepherd, Syphilis, who was punished with the disease by the god Apollo, is anachronistic and disconnected from our modern understanding of the disease, and thus immediately invites mystery and confusion. In preparation for this podcast, I actually reached out to friends and family, mostly people not in medicine, about what ideas, concepts, words come to mind when they hear the word syphilis. And these were some of the responses that I got. Nietzsche, the German philosopher, I actually got him twice. Anguished face emoji. Going crazy. Manet, Oscar Wilde, some kings, Al Capone.
Yeah, we get Al Capone a lot in clinic.
The French, the 17th and 18th centuries, neurosyphilis, sneaky, very dangerous, Tuskegee, you may not know you have it, scary, antibiotics, penicillin, painless genital ulcer, stages, stigma, archaic old person disease, prostitution, infidelity, insanity. Can you actually go insane? I think these responses essentially prove Paul O'Leary's comment, the source of our introductory quote. Correct. Syphilis is like the STI on steroids. It carries the typical stigma we associate with other STIs like chlamydia, gonorrhea, and HIV, but there's an added weight from the inability to extricate it from its sordid history. And the medical profession played and continues to play a huge part in this. O'Leary is essentially calling out from 80 years in the past, telling us that we need to do a better job communicating the facts about syphilis to people. It was really interesting to hear about the names of all the famous people remembered as having or suspected of having syphilis. Before medical school, I would have pictured Johnny Depp from The Libertine, which honestly I never even saw all the way through. But some of those images of him with destroyed face or having gone completely bald in the later stages of syphilis are seared in my memory. But now, having been in the medical profession for a few years, I never even think about Al Capone or Van Gogh or whoever. If I picture anybody, it's the real people I've treated for syphilis, without the glamour or romanticization, but with the very real anxiety and entirely unnecessary but understandable shame. When it comes to medical practice, syphilis represents a cultural clash with medicine of the 21st century. The physical exam is a dying art, and detailed history taking is not far behind. We expect a lot out of our diagnostics, and for most of them, especially in infectious diseases, tests are often sensitive and often specific as well. Think about the swabs we use to pick up genetic material from COVID using PCR technology, or high sensitivity troponin for detecting myocardial ischemia or damage to the heart muscle. For a variety of reasons, syphilis refuses to play by the rules of modern medicine. The diagnosis and management of syphilis demands that a good clinical history and physical exam take primacy, but both of these take a lot of time, our most precious resource. So despite advances in science and technology, our system really sets us up to fail when it comes to controlling this epidemic.
Our recording is definitely timely, as the CDC published the 2023 national data on syphilis in early November. Before I begin, I just want to explain that the gender terms used reflect epidemiological categories used by the CDC, and we do recognize many are not representative of our patients. We may use the terms mother or maternal to describe characteristics of pregnant people, but acknowledge that birthing individuals may be of any gender, and not all birthing individuals identify as mothers. So in 2023, there were a total of 209,253 cases of syphilis, which is the greatest absolute number of cases reported since 1950. Although the overall rate of rise is downtrending, this was still an overall increase of 1% from 2022. There were 53,007 cases of primary and secondary syphilis, which represented the greatest decrease from the previous year at 10.2%. There were 53,573 cases of early non-primary, non-secondary syphilis, and what we know clinically as early latent syphilis, and that marked a 5.9% decrease compared to 2022. We see there were 98,791 cases of late syphilis or unknown duration, which was a 12.8% increase actually compared to 2022, and we think that may reflect an increase in routine screening or delayed diagnosis occurring during the pandemic when STI prevention and care services were disrupted. Individuals with the epidemiological designation of MSM, or men who have sex with men, still account for 32.7%, or about 1/3 of primary and secondary cases. The rate of all stages of syphilis in reproductive age women 15 to 44 years old increased 6.8%, though the rates of primary and secondary syphilis decreased, which was good.
In parallel with this trend, there were 3,882 cases of congenital syphilis, increased by 3% from 2022, and the largest number since 1992, representing about a 1,000% increase over the last 10 years. This included 279 stillbirths or neonatal and infant deaths. Syphilis continues to affect non-white groups disproportionately, with the highest rates in American Indian and Alaskan Natives, followed by Black or African Americans. The rates of congenital syphilis show the same racial disparities. This is attributed to less access to care rather than significant behavioral differences. There is considerable variability by both region and state. The South had the highest regional rate of primary and secondary syphilis, followed by the West. New York State is right in the middle of the pack at 25th, with 14.8 cases per 100,000. HIV co-infection was present in 41% of cases among MSM, 6.5% in men who have sex with women, and 4% in women. It's important to put the 2023 rates into the wider historical perspective. The line graph of syphilis incidence since it was first reported in 1941 to the year 2000 demonstrates a precipitous drop. Picture the U-shaped curve. Since 2000, there's been a steady increase in cases, zooming in on the last 24 years with about an 80% increase over the last 5 years. If we lost you, go ahead and look at the data and accompanying figures, which are available on the CDC website.
Yeah, in general, it appears the overall rise in syphilis incidence was driven by an increase in late stage or unknown duration syphilis, while rates of primary and secondary syphilis decreased, which is good. Looking at the glass half full, we may be seeing the results of increased awareness and screening.
I agree that the overall decrease in primary and secondary syphilis cases is somewhat encouraging, though the truly worrisome trend in these data is the continued high incidence in people of childbearing potential, which is always directly related to continued cases of congenital syphilis. There were a few presentations at ID Week in October that talked about the sobering data from 2022 that indicated about 90% of congenital cases in the US were due to lack of timely testing and adequate treatment.
About a quarter of these were attributed to a lack of prenatal care, but even in those who were engaged in prenatal care, 30% had no documented timely testing for syphilis. Even in those who had appropriate timely testing, 2/3 had documented inadequate treatment, and about 1/5 or 11% of all cases received no treatment or had no documentation of treatment.
These data are all summarized in an MMWR article by McDonald et al. Entitled Vital Signs, Missed Opportunities for Preventing Congenital Syphilis, United States 2022. And for more on congenital syphilis, please listen to the CEI episode from March of 2023 with U of R's own Melinda Godfrey, Program Manager of the Congenital Syphilis Prevention Project, and Dr. Jeffrey Weinberg from Pediatric ID at U of R.
As highlighted by the ID Week presenters and in that podcast episode, there are multiple factors conspiring to make the diagnosis and management of congenital syphilis and syphilis in general difficult, and partly explain why syphilis numbers remain at a historical high in the U.S. Because we're now seeing more cases than in the past, many providers are simply out of practice when it comes to recognizing the clinical manifestations. Another factor is that the clinical manifestations are usually not present, which means we rely on testing, which can be quite complicated. As we mentioned before, testing is different from other diseases in that it is neither particularly sensitive or specific. Let's dive a little deeper into why that is.
As with any disease, to understand its clinical manifestations or lack thereof, as well as the basis of testing and its limitations, it's helpful to go back to its underlying biology. To quote our go-to trusty tome in ID, The Principles and Practices of Infectious Diseases by Mandel, Douglas, and Bennett, syphilis is a complex systemic illness caused by the highly invasive, non-cultivable spirochete Treponema pallidum. This is a pithy statement, so let's break it down by each individual component. Syphilis is complex. I think anyone in healthcare and really anyone in general recognizes this. It's a systemic illness, meaning it affects the entire body and any organ, including our most vital, the heart and the brain. Underlying its systemic nature, the causative bacterium Treponema pallidum is highly invasive into all body tissues, and it's non-cultivable. We'll zero in on this last statement because it's this inability to isolate T. pallidum from patients that's at the root of most of the management dilemmas that continue to surround the disease.
Newer technologies such as PCR and whole genome sequencing have transformed microbiology and changed the way we classify organisms, but we still group bacteria by what they look like. Some like staph and strep take the form of cocci or small round balls, other bacilli or rods, tubular structures like elongated medicine capsules. This is the shape of well-known human pathogens, E. coli or Pseudomonas. Treponemes like T. pallidum are the genus of bacteria we call spirochetes. These take the form of long, stringy corkscrews. The name treponema is composed of the Greek words trep, meaning to turn, nema, meaning thread, and the Latin term pallida, meaning pal. It's all there in the name, a thin, white corkscrew that threads its way into the human body.
Although we hear less about them as a group, spirochetes are nonetheless very important in clinical medicine. The other well-known spirochete, especially in the Northeast U.S., is Borrelia burgdorferi, which, along with some less common Borrelia species, cause Lyme disease, or borreliosis as it's known in Europe.
Other, less well-known spirochetal diseases are leptospirosis, relapsing fever, and endemic treponematoses. The last of these is a group of uncommon cutaneous or skin diseases seen primarily in Central and South America, Asia, Africa, and the Pacific Islands. They're spread by direct contact with some shared clinical features with syphilis, which makes sense because they're actually caused by other subspecies of Treponema pallidum. So even though we talk about T. pallidum as the cause of syphilis, we're specifically talking about T. pallidum subspecies pallidum.
The distinction is important since humans are the only known reservoir for T. pallidum subspecies pallidum. Should we just call it T. pallidum squared? Similar diseases caused by treponemes have been discovered in non-human primates, which provides supporting evidence for the theory that syphilis may have actually originated as a zoonotic spillover from animals to humans, similar to SARS-CoV-2, HIV, and many other infectious diseases. Unfortunately, we don't have time to go into this further, although maybe if we're invited back,
That'd be great.
Get into these more. But it certainly emphasizes that humans do not exist in isolation, but have a complex relationship with the planet and its other inhabitants.
Mm-hmm. And back to the topic at hand. The other bacteria we mentioned, like staph and E. coli, are easily seen under a regular light microscope, the kind we've all used in high school biology classes. But T. pallidum's thin, stringy shape makes it invisible using these same scopes. To see it requires a special technique called dark field microscopy, which essentially applies scattered, tangential light to visualize the organisms. It's more expensive, cumbersome, and like many techniques in microbiology, has become somewhat of a lost art.
And what about PCR? This technology, which harnesses the natural process by which microorganisms replicate by detecting and amplifying unique DNA or RNA signatures, was developed in the 1980s and is now widely used in clinical medicine. There are validated PCR assays for T. pallidum, but none are commercially approved or available outside of highly specialized labs or research settings. Multiple studies in the last few years have studied the added value of PCR and also IgM, another type of serological test targeted at antibodies developed early in disease. Most have found the sensitivity of PCR from blood to be relatively low, especially in early latent or late latent stages, but higher from actual syphilitic skin lesions. A group of Dutch researchers found that the addition of PCR and IgM used in conjunction with clinical and standard serological testing did help detect additional cases of primary syphilis. And PCR does show some promise in the diagnosis of congenital syphilis. And its use on placental or umbilical cord tissue is even mentioned in the 2021 CDC STI guidelines. So in summary, PCR is not currently used in general clinical practice when it comes to syphilis, but it's definitely something to keep an eye on for the future.
So finally, to round out T. pallidum's mysterious qualities, we come to its uncultivable nature. So like the story of PCR, this is not technically true, but practically so. And for decades, scientists have been able to replicate T. pallidum in the lab, but could not keep it alive for more than a few days. This is because during its evolution, the spirochete has dispensed with the usual tools bacteria use for metabolism and scavenge almost all the nutrients from the human host. It's a poster child for the term fastidious. It cannot tolerate desiccation or drying out, elevated temperatures, or high levels of oxygen. Its doubling time is 30 hours compared to about 20 minutes for E. coli or staph. Very interesting.
In 2018, a method of long-term continuous culture using a special growth medium and co-cultivation with rabbit epithelial cells was published by researchers at UT Houston. This builds on decades of research using rabbits as a suboptimal animal model based on another type of treponeme, which is very similar to T. pallidum, called T. paralois caniculi, which infects rabbits. Wow. Suboptimal because rabbits are actually not a great model for human disease and have even led to some misunderstandings over time. For example, previous dogma based on work with rabbits held that T. pallidum produced a delayed type hypersensitivity reaction, like that caused by a bad poison ivy reaction or a positive PPD test for tuberculosis. But subsequent research showed that this is not the case for humans. Even with the recent breakthrough using tissue culture, inoculating rabbit testicles, aka rabbit infectivity testing, is still the only means by which we can recover T. pallidum strains from actual clinical specimens.
Which brings us back to our beloved serological tests. And imperfect as they are, they can be reliable when used in conjunction with a detailed sexual history. There are two types of serological tests: the non-treponemal tests, most commonly RPR, less commonly VDRL, and treponemal tests, which are much more specific to T. pallidum, though as with any test, there can be false positives.
Traditional screening algorithms usually started with an RPR, and then if positive, would prompt a treponemal test to confirm the diagnosis of syphilis, since RPR is less specific. The newer reverse algorithm, which has been widely adopted since about 2007 or so, now starts with the more specific treponemal test followed by an RPR if positive. While both have their advantages and disadvantages, the shift towards the new algorithm came about because the treponemal test became more automated, cheaper, and easier to perform. And at the trade-off of more false positives is thought to capture patients with latent syphilis that we may have missed in the past. In some labs, like ours at University of Rochester, you actually cannot order an RPR alone.
So while we'll not review diagnosis in detail, it never hurts to review some principles of serological testing. And thank you to Pat for the introduction to Dr. Khalil Ghanem. But we will borrow Dr. Khalil Ghanem's 4 rules for syphilis serologies. If nothing else, a reminder to be forgiving of ourselves and one another. Number 1, both treponemal and non-treponemal may be non-reactive in early primary syphilis. After being infected, the body does take some time to produce antibodies in response. Treponemal antibodies tests take about 2 to 3 weeks to become positive, whereas non-treponemal antibody tests usually take about 4 to 6 weeks to become positive. The majority of patients presenting with a chancre have positive serologies, but about a third will be non-reactive and should be retested.
Number 2, both treponemal and non-treponemal antibodies can be falsely positive. As we already mentioned, RPR is known to be very nonspecific. It's an imperfect test and was actually developed in the early 1900s and can be positive in the setting of other infections, autoimmune conditions, immunizations, and pregnancy, which is another reason why evaluation of congenital syphilis can be very confusing. Treponemal antibodies, while more specific, can still be falsely elevated in a similar spectrum of conditions. Because there are other treponemes that live in our mouths and GI tracts, severe gingivitis can cause a false positive treponemal test, for example. This is also another limitation of dark field microscopy. It can't be performed on syphilitic lesions from the mouth and anus because the other treponemes present in those areas will cause a positive test, and we won't know if there's actually syphilis or not.
That's very interesting. Number 3, treponemal antibodies stay positive regardless of treatment. Most people with syphilis will have positive treponemal antibodies for life, which Pat alluded to earlier. But of course, with syphilis, there are always exceptions and deceptions, and a small percentage of patients treated early in the course of disease can revert to negative.
Number 4, non-treponemal antibodies may become non-reactive in persons treated for syphilis but can also decline over time in the absence of treatment. This becomes important in patients with an unexpected positive treponemal screening test, but a negative follow-up RPR. If they had a plausible exposure and no recollection or documentation of treatment, we generally err on the side of treating as latent syphilis if they have a negative RPR. Even breaking it down this way or using algorithms can be confusing. But the underlying theme to all of these rules is that history is key. Both tests are uninterpretable in the absence of information from the patient. In the large majority of calls we get as the consulting ID team for help interpreting syphilis testing, my first suggestion is to go back to find out more information from the patient. Of course, part of why they're calling us is because we know who to contact to the health department or you all at the STI clinic, which is key for providing additional clues about past testing or treatment. History is not perfect, though, and that's why the number of late or unknown duration syphilis cases is so high. When testing comes back positive and there is no or imperfect clinical history, we do tend to err on the side of treating as late syphilis.
While the old serological tests remain the workhorses of syphilis management, there are a few exciting newer adaptations of these tests to different diagnostic platforms and screening strategies. The first is point-of-care testing. Strictly speaking, it's not a new concept, and the first macroscopically read non-treponemal point-of-care card test for syphilis called Syphilis was developed in 1977. Since then, more than a dozen point-of-care syphilis tests have been developed, but until recently, their utility was limited by low sensitivity and specificity. For several years now, point-of-care tests for syphilis have been used in resource-limited settings, and the ongoing epidemic has finally prompted them to be rolled out here in the United States. The FDA now has approved 3 different point-of-care tests, including one that was intended for over-the-counter use. They are qualitative lateral flow tests, similar in appearance and technology to what we would recognize as an at-home COVID test or pregnancy test, but instead of nasal secretions or urine, these require a small amount of blood and test for treponemal antibodies. Importantly, these carry the same limitations as laboratory-based treponemal tests and present a new set of challenges and disadvantages. First, their current price tag of around $30 may preclude use by the people who need it most. Second, they are not intended as standalone tests and should be followed by referral and linkage to a clinician for further evaluation.
One can imagine scenarios similar to what happened when electronic medical records began to release test results to patients in real time instead of having to wait for release or counseling by a medical provider. A positive test, especially a falsely positive, could result in a lot of unnecessary anxiety before counseling and/or confirmatory testing can be performed. And as you mentioned, since it's a treponemal test, some patients may misinterpret a false negative early on in infection as not being infected at all and be mistakenly reassured and never seek care or treatment. On the other hand, it may take out the anxiety of that initial presentation to care and result in increased screening by people who would otherwise avoid getting tested.
Although the FDA guidance specifically recommends against use in pregnant people not engaged in prenatal care, point-of-care testing has already been studied in new, creative ways in the United States. Stafford and al. From UT Houston published data from their implementation of an opt-out syphilis testing program that offered pregnant patients in the emergency department both point-of-care testing and lab-based testing. In the pre-implementation period, 302 pregnant patients presented to the emergency department and only 6, or 2%, underwent lab-based testing per the reverse algorithm when deemed necessary by the treating provider, and all 6 were negative. In the post-implementation period, 322 pregnant patients presented to the emergency department, and 202, or 63%, were approached. Of these, 114, or 56.4%, were tested using either the point-of-care test or lab-based algorithm. 4 patients tested positive for syphilis, and all results were confirmed with lab-based testing. 2 of the patients were diagnosed with early latent infection, and 2 with late latent syphilis. All 4 patients who tested positive by the point-of-care test were treated in the emergency department prior to discharge, and their results were concordant with lab-based testing.
Although not involving POC syphilis testing, a similar approach was taken by Kimberly Sanford and co-authors, who implemented an opt-out syphilis screening program over a 2-year period at a large academic emergency department in Chicago. Based on existing infrastructure and the electronic medical record used to increase HIV screening, their model flagged patients 18 to 64 years old without documentation of syphilis testing within the previous year. They found that compared to the 2-year period prior to implementation, syphilis screening increased from 5,209, or 3.6%, to 37,289, or 24.4% of all encounters. Diagnosis of presumed active syphilis increased from 161, 3.1% of patients screened, to 624, 1.7% of that larger number screened. Importantly, among pregnant people, screening increased from 5.9% to 49.9% of encounters, and syphilis diagnosis increased by 750% from 2 cases to 15.
It's fantastic, yeah. Another creative approach to improving implementation of syphilis care is being carried out through the Louisiana Department of Health. The SHOT, or Syphilis Home Observed Treatment Program, enables patients diagnosed with syphilis but who have documented missed appointment to receive treatment at home along with their partners.
There have also been encouraging legislative changes to address the current epidemic. For example, Washington State approved a law in March of 2024 that allows medical assistants to provide intramuscular injections for syphilis treatment in the field with telehealth supervision.
Great. And another important legislative change specific to New York was the addition in May of 2024 of a requirement for triplicate testing during pregnancy at initial evaluation, during third trimester, and again at delivery. This followed the change to the American College of Obstetricians and Gynecologists recommendations for testing in pregnancy announced in April of 2024.
All of this begs the question of whether we should just implement universal screening for syphilis. While this is not currently recommended, the 2021 CDC treatment guidelines do recommend universal screening if located in a high-risk geographic area. Using the Healthy People 2030 goals, McDonald et al. Defined high risk as a population with a rate of primary and secondary syphilis cases exceeding 4.6 out of 100,000 among females 15 to 44 years of age, and found that this would account for 38% of U.S. counties, which contain about 72% of the entire U.S. population. A recommendation for universal screening does not necessarily mean that it would be done. For example, HIV and hepatitis C is now universally recommended for screening, and we have a ways to go in this front. New York State published guidelines on the use of doxycycline post-exposure prophylaxis for prevention of bacterial sexually transmitted infections, or what we call DoxyPEP. This is based on multiple studies that showed a significant reduction in rates of syphilis, chlamydia, and gonorrhea in people who took a one-time dose of doxycycline 200 milligrams within 72 hours unprotected oral, vaginal, or anal sex. Nick, I know the Monroe County STI Clinic was an early adopter and developed a protocol based on these guidelines. Can you talk about what patient groups for whom DoxyPEP may be appropriate in your experience at the clinic?
Yeah, so currently there is strong evidence for recommending this prevention strategy in gay, bisexual, and other men who have sex with men, as well as transgender women who have had at least one bacterial STI in the past 12 months. There is currently insufficient evidence to recommend use in cisgender women. Some of the benefits of DoxyPEP include that it's sex positive and a user-controlled tool for people at increased risk. Doxy is widely available, cheap, and has a well-established safety record. So to speak just briefly on the use of DoxyPEP in our clinic, we have fields in our EMR that allow any staff member to assess adherence to DoxyPEP, make sure that patients are taking it appropriately at each visit, assess how frequently they use it. We can give refills, and our nurse practitioners write prescriptions for 30 days, 60 days. So we've anecdotally seen that there's been good adherence to that, and we'll have to see if that correlates to a drop in incidence of STIs in the coming months and years.
And moving on to the groups in whom we do not have good data for DoxyPEP, I know I was not alone in my disappointment in the results of the randomized clinical trial of DoxyPEP in cisgender women published about a year ago in the New England Journal of Medicine. In that study, which was conducted in about 500 Kenyan women 18 to 30 years of age who were receiving HIV PrEP, DoxyPEP was not found to reduce rates of bacterial STIs. A few interesting points of this study were that 50 participants were randomly selected to provide hair samples to measure adherence to therapy, and only 29% of hair samples showed doxycycline. So I think one way to interpret this study is that DoxyPEP, if taken, could work, but it doesn't work if patients don't take the medication, which, as you mentioned, is not a small feat.
Sure. And importantly, qualitative analysis from participants in Kenya indicate that stigma, concerns about privacy, forgetfulness, peer influence, pill management, and concerns about side effects, including use during pregnancy, were all factors affecting adherence. These are all issues that could be potentially addressed. And additionally, preliminary data from a recent small observation study in 40 Japanese cisgender female sex workers did show a significant reduction in syphilis, which is good news.
The use of DoxyPEP continues to evolve. As Dr. DeMarco and Dr. Urban recently reviewed in November's CEI episode, Reflections from 2024 CDC STI Prevention Conference, multiple early adapter sites, including San Francisco, Seattle, New York City, and Boston, presented real-world effectiveness data of DoxyPEP. Rates of reduction in syphilis range from 41 to 65%.
The full story of DoxyPEP has yet to be written, and as with any new treatment strategy, there are reasons to be cautious. One of the issues arising from its use is the concern for resistance. San Francisco, an early adopter of doxy-PEP policies, reported data regarding increased rates of tetracycline resistance in gonorrhea isolates. This rise predated the rollout of doxy-PEP, so may not be a direct consequence of its use in that setting, but may reflect more widespread use of doxycycline for chlamydia based on the updated 2021 CDC STI guidelines and for syphilis during the IM penicillin shortage. A reminder that every action in the microbial world has consequences.
Many would say this is an acceptable risk, especially in the setting of the current syphilis epidemic, since we do not routinely use doxy for gonorrhea anyway. And on a related note, all of the gonorrhea isolates from the Kenyan doxy-PEP study were found to be resistant to doxycycline. Gonorrhea is the leading contender to become the next pan-resistant organism, and without getting too much into the weeds, suffice it to say that doxycycline can induce mechanisms of resistance that confer resistance not only to tetracyclines, but to other antibiotics, including cephalosporins and aminoglycosides, which we do heavily rely on for the treatment of gonorrhea.
Other downsides to doxy-PEP are the barriers to implementation, including time constraints, provider biases, ease of obtaining refills, and buy-in from key stakeholders. Some new strategies discussed by Chase Cannon from UW in his talk on doxy-PEP at ID Week include using smart sets in the electronic medical record, nurse-led models, mobile units, and implementing doxy-PEP in places we do not necessarily think of as primary treatment centers for STIs, including college health centers, urgent cares, emergency departments, obstetric gynecology offices, and prenatal care offices. He also noted that there are multiple ongoing implementation trials examining how to optimize the delivery of doxy-PEP.
Another evolving area in doxy-PEP we would be remiss not to mention, especially having reviewed the clear as mud serological test for syphilis, is that we do not yet know how the use of doxy-PEP will affect serological responses in patients using it to prevent syphilis infections.
So with great reluctance, we will move on from doxycycline to other antibiotics that have demonstrated effectiveness or are being assessed for effectiveness against syphilis. Linezolid is an antibiotic much less known than penicillin, currently used to treat various infections, mainly due to gram-positive organisms, but also tuberculosis. Ubals et al. Recently published results of a randomized controlled trial conducted at multiple centers in Europe, which compared 5 days of linezolid to standard IM benzathine penicillin for the treatment of early syphilis. Linezolid failed to meet non-inferiority criteria. Notably, to simplify the treatment regimen, these authors chose a dosing strategy of only 600 milligrams once daily, whereas the standard dose of linezolid for most indications is 600 milligrams twice daily.
A group of researchers at USC are attempting to ask the next logical question of whether a longer course of linezolid and increased dose of twice daily will result in greater efficacy. They presented data at ID Week, which re-demonstrated the effectiveness of linezolid against T. pallidum in vitro, and are conducting a pilot study comparing 10 days of linezolid 600 milligrams BID to benzathine penicillin for treatment of early syphilis.
Cefixime is another antibiotic being assessed by researchers at the USC system. Cefixime is a third-generation cephalosporin in the same class as ceftriaxone, and actually a second-line treatment for gonorrhea. In 2021, Keith et al. Published results from a pilot study that demonstrated similar efficacy of cefixime to the standard of care benzathine penicillin in patients with early syphilis. Now a trial of 400 participants across 11 clinical sites in the United States is ongoing.
To round out our antibiotic section, we will mention that high-dose amoxicillin, given at a dose of 1,000 milligrams 3 times daily, paired with probenecid, which inhibits its excretion and thus raises its plasma concentration, is recommended as an alternative agent for syphilis in the United Kingdom syphilis treatment guidelines. A recent study out of Japan compared this regimen to low-dose amoxicillin, 500 milligrams 3 times daily for early syphilis in patients with well-controlled HIV, and found similar efficacy around 95%, although the low-dose regimen technically did not meet non-inferior criteria.
So to reiterate, penicillin remains the gold standard for treatment, especially in pregnant persons, but it is encouraging to see all the additional exploration of alternatives, especially since we never know when the next drug shortage will be.
Happy 2025, and thanks to everyone for listening.
Yeah, thanks for listening.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.